All right, this is just a review of the material that we didn't get to on Tuesday or today. So let's start with the skin and pigmentation. So we want to make sure that we look at the general pigmentation, the overall skin tone. Is it consistent from top to bottom, or is there one localized area that's different in color than the rest? Make sure when you're looking at the skin, you're also looking in those other specific areas we can see alterations in the tongue, you know, in the oral and hard palate, the soft palate, the conjunctiva, and definitely in the sclera, especially with patients who come in with jaundice. And we're also going to look at nail beds in patients who have that bluish discoloration to their skin or cyanosis. A lot of the documentation we'll be doing is if a patient is normal in pigmentation, is consistent with genetic background. So some of the normal variations that don't mean pathology is freckles, or those very small macule lesions, moles, birthmarks, and then some patients who are going to have lighter pigmentation or even darker pigmentation. So some of the abnormal variations that I need you to know. So paler, that means white. And sometimes when patients come in and we don't know their foundation or their baseline, we can't always tell really if that's their natural color or if they're truly pale. So sometimes we have to correlate to why they're there. But in darker complected people, sometimes they look a little bit more gray, ashen. We're going to look in their conjunctiva, and we're also going to look within the oral mucosa. Sometimes fairer skinned patients may actually have a very light gray sullen color, as we refer it to. And then black or necrosis, that's going to mean necrotic or dead tissue. So if on the next slide you can kind of see that hand at the bottom, that's a necrotic wound that's looks like it's gangrene at this point, so the patient's going to have it amputated. So that could have been from a variety of reasons. The patient could have had an arterial occlusion where they had complete lack of blood flow to that portion of the hand. Could have been frostbite. Who knows? But the tissue's dead and it's necrotic and it's black, so it needs to come off. So we know red or erythema. Another term for that you might have seen in your readings is hyperemia. So kind of increased blood flow to that area. We might see it as increased actual circulation to that area. Sometimes patients who have reperfusion injuries, maybe they've had lack of blood flow to an extremity for a period of time, and then all of a sudden that circulation has been restored, and this massive amounts of blood have kind of surged to the area. Those can be hyperemic reactions. And then some of the patients who it's an inflammatory response, we might see some redness at the site. And some of our patients who actually have venous incompetence, where they pool a lot in their lower extremities because their veins are not competent enough to carry it to the right side of their heart, so erythema. Blue or cyanosis, we talked about in fair skinned patients. We're definitely going to see them in the nail beds and around the mouth first. Usually when you see central cyanosis, where you see it in the trunk and the central portions of the body, the hypoxemia is pretty severe. And cyanosis is always a late sign of hypoxia. And we know in darker skinned patients, again, we're going to be looking in the nail beds, but probably around the lips, a little bit in the conjunctiva. And then jaundice, definitely important abnormal variation that you need to know. So this is from the accumulation of bilirubin under the skin. And yeah, we can see it in the skin, but we're also going to see it in the sclera, the white of the eyes. And then mottling of the skin. This is usually going to be kind of patchy, mottled areas that alternate between purple and red. And this is usually an indication of poor circulation, low blood pressure, poor cardiac output. In addition to the mottling, you're going to feel kind of the cool extremities. Usually these patients, when they have mottling, they're not doing too well. They probably have come in with a massive hemorrhage. They're in shock. So that's a really good picture of jaundice because you can see it really in the skin and in the sclera. Most of the time you'll see it in the sclera first and then the skin. That's a pretty massive amounts of bilirubin. And so we know bilirubin, right, is the breakdown of the red blood cells after they've been utilized. So a lot of times we'll see patients with jaundice who have liver failure, end-stage cirrhosis, maybe hepatitis, viral or secondary to drug reaction. These patients can have various stages of jaundice. So they just aren't able to clear the bilirubin, and the liver's not able to conjugate it to get it to the point where we excrete it through our stool. So unfortunately that it backs up and builds up into our circulation, and we see it manifest in our skin and skin structures. This is kind of a picture right here of the cyanosis, and this is definitely a good picture of a hyperemic reaction. It almost looks like an allergic reaction. So we've talked before about temperature. We're always using the dorsal or the back part of the hands. When we're assessing temperature, we're assessing hypothermia or hyperthermia. There are definitely normal variations. Our patients that are in the OR or they're being recovered after surgery, those patients have low body temperatures, not only from anesthesia, because it drops their metabolic rate, but the operating room is cold. Okay? So that might be a normal variation, but where we know exactly why their body temperature has dropped, and we can fix that. Patients who are hyperthermic, exercise, fever from being sick, those are normal variations that, we know what's happening, and they're eventually going to go away. And so any type of a normal finding is, outside of these norms. So a lot of times we might see hyperthermia that's related to head traumas or strokes, where the hypothalamus, where our natural body's thermostat is altered, and it doesn't have the ability to turn it on and turn it off to help cool. So people with head stroke or strokes, head trauma, the hypothalamus can be altered. And moisture, we know obviously between diaphoresis and dehydration. Some of the things that we're going to see when we're assessing or palpating the skin for dehydration: dry, cracked lips, oral mucosa, and then we're going to see tenting. We're going to talk about that when we get to the mobility in the turgor section. But perspiration is normal with certain things. Exercise, maybe a little bit of fever, those things are normal. Our problems with diaphoresis is when it's profuse. We know as far as with heat stroke, when patients are still sweating, we know that that's a good sign. But, when they start to get dry, it usually means that, they're starting to get dehydrated, and then they don't have the mechanisms anymore to cool themselves. So that's when you start worrying more about, cardiac arrest and death. So texture and thickness, we know it should be smooth and firm and fairly even, except when we get to the palms and the soles, right? Those are going to be the hardened work areas, so we're going to have a lot more calluses. So any kind of abnormal finding would be abnormal thickness, not in those areas. And so, there are specific diseases known as hyperkeratosis, where there's an overproduction of that first layer of the epidermis. And so actually on the hands and all over the feet, these patients can have very thickened, rough, scaled hands and feet. And so that would be kind of an abnormal variation. And then edema, we talked about this the other day a little bit. We have a scale, and usually we find it between pitting and non-pitting. We can have localized edema to an injury, inflammation, or we can have it secondary to a chronic disease like heart failure or chronic kidney disease. So we can look at it, but we also need to palpate to see if it is non-pitting or pitting. So we've got the scale from +1 to +4. I would say +3, +4, you're really going to see in patients who have end-stage right-sided heart failure. It's where the right side of the heart can't push the blood to the left, so it starts to back up down into the venous circulation, and that's where it accumulates. Like we said, we can see the edema in our lower dependent extremities. We can see it in our arms, upper extremities, face, within our abdominal cavity, which is known as ascites. And sometimes we can see massive amounts of edema all over, like +3, +4, and that term is known as anasarca. When we have just overall edema, maybe not so massive overall, we might refer to that as generalized edema. So mobility and turgor. So how easily does the skin rise and snap right back into place? So that's exactly what it should be. Tenting is considered abnormal variation. So if we pull up the skin and it takes a while to go back down and it actually tense, that's a problem. You know, most places we can do this is on the top of the hand, we can do this on the forearm, or we can also do it underneath the clavicle up the top of the sternum. I wouldn't forget that. We need to make sure in the older patients we're doing it on the chest versus the hand, because sometimes older patients' skin by their hands and arms is pretty, it sags a lot. So some of the vascular lesions let's talk about is petechiae and purpura. So these are both some pictures. On the left is petechiae and on the right is purpura. So they're both capillary rupture problems, and most of the time when you see petechiae or purpura, your platelet count could be low, your clotting factors could be low. These patients are kind of spontaneously and random developing these petechiae and purpura. So you usually worry about bleeding risks in your patients like this. Multiple disease processes that could, risk for this is idiopathic thrombocytopenia. So when a patient's platelet count drops significantly low, sometimes allergic reactions to heparin, their platelet count can drop significantly. All the platelets can be used, and then we're not creating more. Okay, so these patients are at risk for bleeding. So we're going to see these pinpoint macules that are just going to be flat, but you're going to see them all over. You can see them anywhere, but this looks like it's in their lower extremities. And then the purpura is more of a convoluted, confluent pattern where there's larger patches of it, but it's kind of ruptured capillaries, leakage of blood underneath the skin. They don't form like hematomas. And then we know bruises. We kind of talked about this a little bit. We worry about multiple bruises, frequent visits to the ER, definitely localized patterns, different stages of bruising. We think above the waist, our real concerns are for abuse. So we need to make sure that we evaluate, the color, location, and size, and if there's various bruises with different stages of healing. And then, find out from the patient exactly what happened to make sure it's consistent, with the injury. And so if you look here at this picture right here, you can see the different various stages of the bruising. And all it just means is, over time it's a little bit more cyanotic, red, and this is because of the loss of hemoglobin from the collected blood under the area. And then as the hemoglobin starts to get broken down and the red blood cells are actually lysed and broken down into bilirubin, you're going to see it where it's more yellow. So it's just kind of the loss of hemoglobin, oxygen from the red blood cells that are collected, the breakdown of red cells, hemoglobin, the creation of bilirubin. All right, so now rashes, we need to assess and do a more configuration pattern and determine if it's a primary, secondary. So the location and pattern, is it more than just where you see? Do we need to kind of look within the crevices, look in more non-suspicious places? When we're inspecting lesions, especially if they're open, we always need to make sure we wear gloves. We're going to need to make sure that we measure. It's very appropriate, especially the length, width, and depth if it's an open lesion. But if not, just making sure that we get an accurate circumference of it. Do it in depth, like recent history of how the lesion happened. And is there any other signs and symptoms of localized infection or systemic? Lacerations, as long as they're kind of clean, concise, and not deep, they can be treated very easily. I think it's the ones that you worry about where they've been more traumatic wounds, like, out in an open field, motor vehicle accident, where the laceration is not only deep, but it's dirty. So when we're looking at the hair, we are going to wear gloves. We should. So we're going to be looking at the condition of the scalp and the surface characteristics of it. Are there any bumps, tenderness, or lesions? We're looking at the amount and distribution. Are there consistent with older age baldness? Or are there specific actually patches that aren't consistent with balding in an older individual? So we're seeing maybe baldness that with certain lesions, patches or crests on the scalp that might be consistent with psoriasis. Looking at the color, and then the hair texture. Is it thin? Is it thick? When we're looking at the nails, we know a normal angle is somewhere around 160 degrees. And when we're looking at the nails, we're always looking at consistency, color, and contour. So are they square? Are they oval? And we want them to be smooth and regular. Are they translucent and pink? Does it have good blood flow? We're always checking the capillary refill. You can do this on the fingers. You can do this on the toenails. And we want the color, when we press on it, to kind of blanch the nail bed. When we let go of the nail bed, we want it to return to normal pretty closely, like pretty quickly. So anything less than 3 seconds is okay. Anything greater than 3 seconds is prolonged. It's considered abnormal. And we know one abnormal condition to talk about is clubbing. So anytime you have an angle that's greater than 180 degrees, so we said anything less than 160 is normal, but anything greater than 180 is consistent with the condition known as clubbing. And usually you're going to see it in patients who have chronic lung conditions like COPD, emphysema, pulmonary fibrosis. So these patients have chronic states of hypoxia in their blood. And as a result, I guess the nail shape kind of grows over and it kind of takes on this club appearance. And I think some of the literature says it's related to excessive growth factors that are released and secreted by the lungs. All right, so anytime we see a mole or a nevi, we need to make sure we do an ABCDE skin assessment to make sure we determining, is this benign or could it be malignant? Okay, so this is not only something we're going to assess, we're going to make sure our patients know how to do this as well. So I'd make sure that you're familiar with the skin assessment. So A, we know, is asymmetric. So are both sides symmetrical? Do they look the same on both sides? Is there a consistent border between the mole or nevus and the surrounding skin, or is it kind of overlapped? So is there clear definition between the mole and the surrounding skin? Is the color all one, light, brown, or are there different variations through it? Brown, black, red. So I would say that those are the three kind of most important things. Some of the literature does say anything greater than 6 millimeters might be consistent with malignancy. And has there been a progression or an evolution from where it started to where it is now? All right, so let's talk about lesion patterns. So we know one configuration is an annular or circular, where it starts from the center and it kind of moves its way out to the periphery. And we know we think of ringworm or tinea corporis. Okay. It almost looks like you took a car cigarette lighter and you put it on the skin. That's exactly what it looks like. We know a confluent lesion pattern is where it kind of runs all together, like so hives, eczema. Discrete, where some of these lesion patterns where they're singular, they're by themselves, and this could really be anything, but it's very, so I think this picture is like skin tags. Gyrate, this could be more of like an S shaped. This looks like the typical pattern you might see with somebody who has psoriasis. Grouped, this could be eczema as well, dermatitis. The linear could be a little bit of a psoriasis as well. The polycyclic could be where there's multiple groups of single, and then the zoster form we know is more consistent with herpes zoster or shingles. And we know the zoster form appearance takes on because of the spinal nerves where they innervate at the level of the skin. So the lesions that we see on the outside is from where it breaks through from the spinal nerves. And so we're usually going to see them somewhere along the sides, along the chest, upper back. Okay, so some other lesion patterns we might see is a target, And I think this picture right here is kind of consistent with like a bullseye appearance with somebody who has Lyme disease. And so other types of primary lesions, so a macule, we know this is a flat lesion that is not above the skin and it's less than 1 centimeter. And it's really the difference is just there's a color variation. So we think of freckles. A papule could be similar to a macule, but it's actually just elevated above the skin. So small, less than 1 millimeter, 1 centimeter, but it's just elevated above the skin. So we might think of a mole or a nevus. All right, so our nodules, so we usually think of like fibromas or fibroid tumors. So this is going to be a solid elevated tumor that's going to be larger than 1 centimeter. And it's going to start to extend down into the dermis, so it's pretty deep. And now a wheal, we think of, there's fluid, and we usually think of mosquito bites. Sometimes we think of wheals when somebody has had an injection with a TB, tuberculosis, check to see if people have been exposed to anybody with tuberculosis. We refer to those as wheals because we actually create a little fluid under the skin to check to see if there's a reaction. So we know vesicles, we know there's going to be free fluid under kind of a cavity, and this is going to be up to 1 centimeter. And whenever we think of vesicles, we might think of it as chickenpox, or we might think of it as varicella or as herpes zoster with shingles. So vesicles that have fluid underneath it, that might be in like a zoster form pattern. And then once they rupture, they tend to kind of crust over and dry. We know a cyst is going to be a fluid-filled cavity that extends deeper down into the dermis or the subcute. And we obviously think of a sebaceous cyst where there's an accumulation. And then obviously a pustule, there's going to be this accumulation of pus, turbid fluid in the cavity. And so we always think of anything like acne or impetigo. So some of our secondary skin lesions might be a crust. And we might think of impetigo as well. We just talked about the kind of the lesion patterns with the purulent fluid collected. But sometimes, again, they're going to have crust around the pustules. And this, we know impetigo is a bacterial infection that's pretty contagious. We see it a lot in kids, kind of around their mouths, on their face. We can treat it with antibiotics. Again, it's pretty contagious and it looks very painful. And so scales, a lot of these, you're going to see these in patients with psoriasis or dermatitis. And it's very, it can be very dry or greasy, but it looks more silvery white. And it's kind of flaky. So it's not dandruff, but it's just a lot of excess keratin or skin. And so when it flakes off or sheds, it can take on the appearance of dandruff, but it's more thicker. And then fissures, we know it's a linear crack that extends down into the dermis. It can be dry or moist. And we know that this can be related to cheilosis or cheilitis, where there's the inflammation and the cracked lips. It could be from dryness. But we can also see fissures in patients' skin in certain locations where there's been a lot of irritation and maybe incontinence. So we might see the breakdown of skin that way. Erosions. Well, usually when we think of an erosion, we can kind of think of a skin tear. But we also think of like maybe a stage 1 pressure or a stage 2 pressure ulcer, where that first layer of skin is kind of eroded away. So sometimes it may be related to pressure, and sometimes it may just be from somebody who's got frail skin and they bumped up against a piece of furniture or the wall. And so because it's just that epidermis, healing is not going to be a problem because it's very superficial. So it doesn't have to go through the process of building any more of that dermis tissue to fill in. It's going to just heal very quickly. And then we know ulcers when we talk about pressure ulcers. So we can have various stages of pressure ulcers, 1 through 4, just depending on the depth. And we're going to talk about this in a couple weeks in 501. But it just depends on the different depths of how far it is into the epidermis, down into the dermis, or even if it's far through as the bone and the muscle. And so usually the deeper ulcers that are kind of the partial thickness or full thickness, they are going to take a lot longer to heal because the actual dermis, the new granulated tissue, needs to fill in and grow first before the top layer of the epidermis grows over. So it has to heal from the inside out. So yeah, we think of pressure ulcers, we think of ulcers. And then excoriations, we think of that with irritation, itching. So usually these are self-inflicted wounds from patients who've especially got nails where they've scratched themselves. So some secondary skin lesions, right, a scar. We know this is normal. It's a fibrotic change from the healing of maybe a surgical wound. And it's where normal tissue is replaced with connective tissue. So yeah, the scar, it's closed over, but it's still fairly weak from where it was before the new tissue took over. The older tissue is probably stronger. And we know atrophic scars are the stria or the stretch marks. And usually this can be from the thinning of the epidermis, but it can also be from massive amounts of overstretch in the dermis. So the dermis is just stretched way too quickly, and then you're going to see these stretch marks or stria. The chinifications, we usually see these when patients who have had eczema or maybe an allergic reaction and they've scratched to the point that they've caused their skin to become very thickened and tight. And it actually takes on this kind of moss appearance. And we know keloids are more of a excess or hypertrophic scar. So where somebody has a genetic predisposition to having an abnormal scar tissue development. And we do see this a little bit more frequently in African American population, but it is genetic. So it could be from somebody who just has surgery, and so they develop a hypertrophic scar. Or it could be somebody who gets their ears pierced, and the back of their earlobes, they develop keloids. All right, so the skin, hair, and nails in the older patient. So we know a couple of the normal variations as people get older and they have certain areas of their skin that's exposed to the sun is we know senile latinogens or liver spots. So we typically can see these on the face, maybe the hands or the arms where the patient has been in the sun frequently. And so all they are is a cluster of melanocytes in these sun-exposed areas. And so no, they're not precancerous, and no, it doesn't necessarily increase the patient's risk of developing skin cancer. And so keratoses, these are a little bit different. They're also related to the exposure of sun and sun-exposed areas, but they tend to look a little bit more unsightly than the latinogens. They're a little bit more scaly and kind of clumped together, and sometimes they look white or greasy. And again, doesn't increase the patient's risk for developing cancer. And we know skin tags, these are also just normal overgrowths of skin. And so they don't necessarily increase the patient's risk for cancer, but they can be kind of irritable, especially if they're in bothersome areas. So sometimes they can just be quickly removed. And so a pressure risk assessment, the most common risk assessment tool that you're going to do to determine a patient's risk for skin injury or pressure ulcer development is the Braden scale. Okay, and it's going to be the one that you guys use in the hospital when you start doing your clinicals. And just depending on the different sections or topics that you have to answer based on the patient, it will give the patient a score. And the lower the patient's score, the higher the risk they are for pressure ulcers. And so depending on where they score on the risk assessment tool would be depending on kind of the interventions that you perform to make sure the patient doesn't develop pressure ulcers. All right, so the musculoskeletal chapter, I would just take a look and review the joints, the bones, and the muscles if you just need a quick review. So when we're talking about a subjective history on these patients, we're thinking about pain, right? Where is the history of the problem? Discomfort, when did it start? How long has it been going on? And so we do a full PQRST based on any kind of subjective complaints a patient might have with their joints, bone, or muscles. And most often you're going to think, okay, pain, right? Maybe a little bit of stiffness, swelling, heat, crepitus, and that's that feeling when joints are actually rubbing together, when a lot of the cartilage and the inner workings of the joint have been eroded away. So that noise that we can audibly hear without anything is known as crepitus. Do they have the redness? And so again, these are all consistent with somebody who's got osteoarthritis, rheumatoid arthritis. So when you think of somebody with musculoskeletal problems, they might have some tendonitis or bursitis. Do they have any weakness? How is their range of motion? Is it limited, or do they have full range of motion, depending on, the affected extremity? And I think in addition to kind of really going in deep with the patient's complaint, we're also going to look, okay, what led to this? Was this just a gradual degenerative process, or did the patient truly have a trauma or an injury? And then we're always going to look at how is this affecting the patient's daily life? Can they perform ADLs? Can they perform IADLs? Their self-care behaviors. So that's always an important component what we're looking at, in addition to just the subjective complaints. How does it affect their self-care ability? So again, the self-care behaviors, some of the risk factors for some of the musculoskeletal injuries, occupational hazards, nurses, big one, construction workers, anybody that's doing a lot of repetitive heavy lifting, even people that are constantly working with their hands, repetitive motions, increased risk for carpal tunnel. Anything that puts a lot of stress on the joints. And medications, what are you taking? Are you taking any anti-inflammatories, over-the-counters, or that were prescribed to you by another physician? Any muscle relaxers? Are you taking any types of herbals? And when we're inspecting, we're going to look at the patient's posture, the alignment of their extremities in relation to their posture, the contour, the size of their muscles, their joints. Are there any gross deformities? You don't have to be an orthopedic surgeon or a PA to be able to see gross deformities in somebody with their posture and the alignment of their extremities, especially when they're having pain. We're looking for edema. Is it pitting? Is it non-pitting? We talked about their range of motion. Do they have masses? In their gait, when they get up and walk, is it smooth, even? Is it symmetric? Are their arms hanging? Is their head pointed directly? Is there that concave S appearance to it? And then when we're palpating, kind of the same things. We're inspecting and palpating at the same time. And so a lot of these things make sense with osteoarthritis, bursitis, tendonitis, tenderness, heat, edema, or masses. In addition to their range of motion, we're also going to look at their muscle strength. And we also talked about, the presence of crepitus over joints. We can hear this in a lot of different joints, but we really do think about it in the knees in patients who have had, osteoarthritis that's fairly severe when the patients are just more or less bone on bone. The range of motion, this can be active or passive. So active, if the patient can fully participate in themselves, and the nurse can help to stabilize the joint to make this more comfortable for the patient if they need it. But if passive is if the patient is unable, if they're paralyzed, incapacitated, the nurse is going to have to do this. And so whether it's active or passive, we know that the range of motion, the angle should be the same. And so we were going to be documenting as it's full range of motion or limited. And obviously we go much more in detail with the limited range of motion. So when we're testing muscle strength, we're doing it on a grading muscle scale of 0 to 5. And so the highest would be 5 out of 5, and then the lowest would be 0 out of 5. And so we're really testing muscle strength to gravity or to resistance. And so, you can do this with tons of muscle groups, But you always need to make sure that you do it bilaterally to assess when you're checking. So if you're doing the biceps, do we have a 5 out of 5 on our right, or do we have a 3 out of 5 on our left? So if patients have had head trauma, strokes, brain surgery, those might be some things to consider if we've got a discrepancy between muscle strength on one side and the other. So a 5 out of 5 would be if the patient has full range of motion and like their muscle strength against gravity and full resistance. So if they're able to pull their arm up to gravity very easily, and if they're also able to kind of push against somebody pushing against it with full resistance, that would be a 5 out of 5. So obviously that's the optimal number that we want. And skeletal muscle movements, so more like our range of motion. So I'd be kind of familiar with a few of these terms, like pronation, supination, definitely circumduction. So if the patient has to take their arm all the way up and around, and you don't have to go into great detail, but I would know the more common ones. So flexion and extension, definitely. Adduction, abduction, those are all very key skeletal muscle movements, range of motion to know. It's not necessary to really remember or know the angles or the degrees. So with our aging adult, we know one of the biggest risks, in addition to osteoarthritis, degenerative changes, these patients are at risk for osteoporosis. And most commonly, we're going to see these in the white female as they get older, usually around the age of 25 to 35. The peak of our bone density peaks, and the bone remodeling process, once we kind of hit 40 or once we start to hit menopause, it starts to kind of alter and slow down. So bone resorption, or kind of the release of calcium from our bone to our bloodstream, starts to kind of override that bone building process. Okay, so we kind of have that offshoot of the bone remodeling, and so our bones start to become a little less dense, weaker. Okay. And so some of the other changes we might see in the aging adult, coupled with osteoporosis, that's going to increase their risks for injury, is we're going to see some of the postural changes with their height. Maybe they're going to have a decrease in height from their vertebrae that are kind of shrinking, that kyphosis, where there's going to be that curvature, a dowager's hump. And so we just kind of talked about this. Whiter females who are more frail are more at increased risk for osteoporosis. It's something about estrogen levels in African American Latinos that kind of actually block or decrease their risk of having osteoporosis as much as white females. So their bone density remains a lot higher, therefore they're at decreased risk for fractures from falls or even spontaneous from vertebrae. So we talked about a Braden, so a pressure ulcer risk assessment. We're also going to do fall risk assessments on all of our patients in the hospital as well, and it's typically referred to as a Morris Fall Scale. Okay? So there are different questions that's going to be built into EPIC, and you'll probably do this about once a shift. And you're just going to look at certain things like the medications the patient's on that could possibly put them at risk for falls, if it makes them orthostatic, dizzy. Has the patient had any falls in the last 6 months? Are they at risk for falls secondary to why they're in the hospital? Are they using assist devices? Do they have weakness? Any kind of mental or cognitive delays? So those things would predispose the patient to falling.